Hi Beth, thanks for talking to me today. Can I just ask you to introduce yourself?
Hi, yeah, sure. My name's Beth Kerr. I'm a GP in the Scottish Borders, and I'm also GP lead for cancer and palliative care here. In addition to these roles, I'm primary care co-lead for digital dermatology at the Centre for Sustainable Delivery. So my various jobs all intersect in the Scottish Cancer Referral Guidelines for dermatology.
You're going to be covering the skin guidelines today. Can you just tell me what the key changes to those guidelines have been?
Yeah, so firstly, like all the guidelines, there's updated data to understand the context of cancer in Scotland in 2025. So, for example, for dermatology, it's useful to understand that there are more urgent suspicion of cancer referrals for skin cancer than for any other site. Skin cancer referrals have increased more than threefold in the last 10 to 15 years. And of the cancers diagnosed, BCC, basal cell carcinoma, is the most common type of skin cancer, around 75%, and melanoma accounts for only about 1%. There's also new, really clear information on risk factors. A big improvement is the new section on clinical assessment. It gives much more detail on what to look for each skin cancer type and highlights suspicious features. So, for example, for melanoma, we're all familiar with the old ABCD criteria. And we now have the addition of E for evolution, so changes in shape, size or colour, especially if changes are occurring quickly. And also the new ugly duckling sign has been added, which refers to looking out for a mole that doesn't look like anything else around it and stands out as different. The urgent suspicion of cancer referral criteria have been based on these clinical features in the new assessment section, so it's important to read both sections in conjunction with each other.
You just talked about risk factors. What risk factors are we looking for?
So there's a new section on risk factors, and this is obviously helpful for assessment and for considering who most likely needs an urgent referral. And it's also worth referencing these risk factors in your referral text. So some of the risk factors apply to all skin cancers. So that would include sun exposure and sunbed use, particularly in those with fair skin or those that burn easily. For melanoma, risk factors include a large number of nevi, so over 100 increase the relative risk sevenfold compared to under 15, and a family history of melanoma. For SCC, multiple small actinic keratoses, high levels of UVA, phototherapy, and being immunocompromised increase risk. And in fact, it mentions immunocompromise separately as well, that any concerning unexplained skin lesion in an immunocompromised person should be referred as urgent suspicion of cancer. It's also, I suppose, important to mention here, because it's highlighted in the guidance, that skin cancer can affect people of all skin colours. So although fair skin is mentioned as a particular risk factor, it's important not to overlook the lesions in people with brown or black skin. So in people with darker skin tones, lesions can often occur in areas that get little sun exposure, so palms, soles, under around the nails, and these have a higher risk of later diagnosis and resultant poor prognosis.
A guidance is split into assessment and referral parts. What is significant in this section?
So firstly, in terms of general assessment, we are advised to examine the lesion with a dermatoscope. Dermatoscope's useful particularly for distinguishing benign pigmented lesions, so seb keratosis, from melanoma, and potentially reduces unnecessary referrals. But it also recognises that not everybody has one, so it's just if you're trained and have one available. Then, if the lesion is suspicious of cancer, a full medical history should be documented and the entire skin surface examined. History should include drugs, conditions that cause immunocompromise, and a previous personal or family history of skin cancer. The new assessment section is really detailed in comparison to previous information, as I've already mentioned. So it's divided into skin cancer type, so melanoma and subungual melanoma, SCC and SCC of the nail apparatus, and BCC, as well as other additional features that are concerning of malignancy. In each section, there are then clinical features to look for. So, for example, the features I've already mentioned about melanoma, so the ABCDE criteria, the ugly duckling sign, and also a new mole in anyone over 40. For BCC, for example, it's to look for a raised rolled edge, pearly waxy nodule, some scar-like tethering or a reddish plaque. It might have prominent blood vessels or easy bleeding, and the BCC is rarely painful, comparing to an SCC, which does tend to be painful or tender to touch and is fast-growing over weeks to months, and it can appear as scaly, as a nodule, indurated or thickened lesion, and it may also bleed easily like a BCC. This assessment section then feeds directly into the referral section with referral advice based on the cancer type. So, for example, for a skin or nail lesion suspicious for melanoma or SCC, refer as urgent suspicion of cancer. A skin lesion that you're suspicious of a BCC, basal cell carcinoma, if it's invading a potentially dangerous area, so periocular, the auditory meatus, nerve or major blood vessel, then also refer for urgent suspicion of cancer.
I think the last section is about good practice points. What's included in this section?
So the good practice points include advice on assessing non-cancerous pigmented lesions. For example, details about seborrheic keratoses, their classical stuck-on appearance that can change in colour, size and shape. We need to positively recognise these benign lesions and not refer, as if we rigidly applied the ABCDE criteria to these lesions, we'd have unnecessary referrals. There's also links to the Right Decision Service to support us managing lesions that aren't referred. And additionally, the role of the GP with a special interest in dermatology is highlighted, for example, to manage some of these lesions in primary care or for the excision of a BCC. Another good practice point that's highlighted is the importance of sending a photo with a referral. So a dermatoscopic image, as we mentioned, would be the gold standard, but to simply include a clear image is still extremely helpful. The old adage, a picture paints 1,000 words, stands here. So a triage quality photo really assists secondary care to appropriately place patients onto their correct pathway as quickly as possible. All boards in Scotland now have access to the new National Consultant Connect pass-through app, which allows images to be easily taken on a clinician's phone, and then it's not stored on the phone itself, so it's very safe and IG compliant. The images are then stored on a national digital platform, and they get pulled onto a Skype Gateway referral, which is our method of doing referrals to secondary care with a click of a button attached from the NDP. And then secondary care can view those images once they've been attached to the referral. And the last thing just to mention is that guidance also advises to include a full accurate description of the lesion in addition to your photo, including size with measurements and any pain or tenderness.